But yeah, I agree with that. I think we can definitely try to make that
Yeah, it's just circles
connection.
of influence.
Absolutely. Absolutely. All right. Anyone who might be in attendance, just hopping over to Facebook to make sure that we are there, and we indeed are. So let's not keep you waiting any longer. Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this month, every episode, and I am a filmmaker and a writer, among a few other things, as our guest and I talked about before the show started. But I've been working with CCF in that capacity for over a decade now to create video content, different kinds of video content, live video series like what you'll see today, patient-centric documentaries, treatment-based videos, conference videos, et cetera, over those 10 years, but all with the same singular mission in mind, and that is to educate people, to spread awareness about neuroendocrine tumors. That is what we're here today. Now, the value of this show, and I say this every episode, and I genuinely mean it, is twofold as I see it, and that gets echoed from the community, is one, the information that you will get from our guest today, and two, the support, the camaraderie or solidarity, the community that exists in the overall net community, which is extremely strong, and also in the kind of smaller community that we've cultivated here at Luncheon with the Experts. So I say that to say, I want you, if you're new to the show, first of all, welcome. And I encourage you to embrace that community. You can see in the comment sections that people are starting to say hello and good morning, good to see you again. Hi from North Carolina, hi from Wisconsin, from British Columbia. Introduce yourself. Tell us where you are signing on from in the world, and embrace this community, because I assure you they will embrace you back. And the shared experiences and shared stories from other patients and caregivers in this space, I think is just as valuable as the information that we discuss. So make sure you leverage that. Before we get started, we always want to thank Ipsen Biopharmaceuticals, our presenting sponsor, because we couldn't do the show without them. But we do have this disclaimer from them at the top of the program, and that is that the opinions expressed by our guest presenters, as well as the questions asked by the audience, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. So, this is the main takeaway. Audience members should not rely solely on the opinions or information expressed by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Like all disclaimers or legalese, it's lengthy and it's wordy, but the point is, we or our guest almost certainly doesn't know your specific case. And I am not a medical expert, but the one thing I have 100% learned in the 10 years of working within this space is that every case of this disease is unique, and therefore every path and plan forward is as well. So take the information that you get today and the answers to your questions back to your home team, which does know your specific case, and that way you can make the best path forward for you. Okay, so today I'm excited to welcome back to the show for the so many times I've lost count, Dr. Mary Maluccio. Good to see you, my friend, and welcome back to the show.
Hey, Rain, it's great to see you again. I feel like it did. I had a stint there where it was like 3 in a row, and now
Totally.
I feel like, yeah, you look the same. I hope I look the same, but
you do look the same, and I
look the same.
appreciate you saying that, because we also discussed before we started the show that I have 2 kids under 5, and I don't feel the same sometimes. So it's good to hear that. For those people out there that may not know you as well as I do, tell the folks in attendance, which the numbers are growing very quickly, which I'm excited to see, who you are, what role you fill in this neuroendocrine tumor community.
Yeah, great. So I'm Mary Maluccio, and I run the neuroendocrine program in New Orleans. And I took this job now almost 4 years ago. God, it seems like I have been down in the South for a lot longer. So I took over this program around 4 years ago from an icon in the field named Jean Woltering. Yeah. And we have managed to get through the entire pandemic, even though almost 40% of our patients come from out of state. And we are a neuroendocrine subspecialty center that caters to the South, predominantly, Arkansas, Oklahoma, East Texas, Mississippi, Louisiana, some parts of Alabama, the Florida Panhandle. and it's been a great experience. So our program now, the only thing that's changed probably since I was last on here, we did ultimately partner under the umbrella of a different health system, and that has been going really well, and it's predominantly been super encouraging to see us be able to bring clinical trials and novel therapies to a part of the country that I just feel had not been included in those for probably decades. So it's been really great. All is good.
Excellent, excellent. And I, as I said earlier, have been working with CCF for I guess it's close to 12 years now. So I had the pleasure to work with Dr. Gene Woltering a few times in that course. When I came on, we've seen this kind of transition of kind of the, I don't know, the old guard, if you will, of these titans, right, of neuroendocrine tumors, and now we're seeing younger doctors all the time, and I think that's very exciting because the ability to diagnose and treat this disease is continuing to get better. And as we also talked about earlier, there's so much activity going on right now, and I'm sure that people will ask questions about that today. The first thing I am going to ask a question. To get us started, I see, and for the folks watching, if you can see in the back of Dr. Maluccio's screen, she has this big "Yes, you can" over her window there, which I just love those sort of affirmations and things like that. And she showed me that those kinds of quotes and sayings are all over her office. And not only that, she has like travel imagery, destinations in her office, like playing on a screen, and all this like positive kind of attitude stuff. And I don't want to misspeak and call it something it's not. But my question is, Dr. Maluccio, talk to me a little bit about your thoughts, your approach to this holistic general wellness, concept, or like I said, approach when you are a cancer patient. What are the other things that could help psychologically, emotionally, mentally?
Yeah, I think that's such a great question. And I think that I never want to cliche that whole sort of well-being
I
thing,
get
but
it.
I have
Yeah.
actually been on advisory boards where some of the patients that sit on those advisory boards and try to give perspective feel like we're doing a lot as a community, even if it's just outside neuroendocrine, but within neuroendocrine, where we're doing really great to try to take away the burdens of the active cancer treatment
Mm-hmm.
and how we can streamline, make it easier, patient housing units and things like that. But that we just don't have the bandwidth or haven't had the bandwidth to focus on the emotional, the psychological, the impact that it has on your family unit, your relationships, your own ability to really be living your best life. So I think that if you were to really focus on in general, what a lot of organizations are trying to do is to just
Mm-hmm.
focus on well-being. And so I think that there are clearly strategies, and we do go over those strategies when people are coming in here and saying, hey, these are the burdens. And yes, I don't want to focus on the burdens because those are the negative, but it's just that we can't really control the fact that we have the disease. So we can go over active treatment, but we can go over some strategies on how we can try to decrease some of those emotional or just mental barriers to get you through some of the hard times.
Absolutely. I think it's very, very important. One more thing. This is more of an announcement. I have to step off camera for a second, but I want to make mention of this because something this is very meaningful to me. One moment. So I just wanted to send a special thank you to one of the Luncheon with the Expert attendees, Jim, who sent me this pair of zebra socks. And it was so meaningful and so sweet with a beautiful letter too, which I won't take any more time away to read. But thank you, Jim. That meant so much, and I will wear them with pride. I genuinely feel very honored to be allowed to be a part of this kind of overall community. So thank you for that. Just wanted to make mention of that. Let's take some questions, Dr. Maluccio. Now, I actually had a question that came in beforehand, which now we're going to different platforms, to YouTube and LinkedIn, etc. And there was one question I had that says, does Dr. Maluccio have any books or articles about treatment of lung carcinoid cancer with liver lesions? Any thoughts on that?
Yeah, so bronchopulmonary neuroendocrine are kind of the rare within the already rare. But I will tell you that there is a lot known about it, and there are people within our community that live and breathe. They call the lung noids. But the question was really about, are there established books, papers, is there anything? Well, all of that is really going to be guidelines, because that's the one patient population that doesn't seem to necessarily behave like the same. So if it's limited to the lung, yeah, we feel pretty comfortable that behaves a certain way. We can give people short-term and longer-term expectations. But once it's metastasized outside the lung, that's a lot trickier. So those are the types of things that are super individualistic. You will not find the answer in any one paper or any one textbook. But that I will also encourage people that if it helps you reconcile the medical decisions that you're making, I highly recommend that's a second opinion situation. Even if it's to hear the same words come out of another doctor's mouth, it really makes you feel that the rarity of your tumor is not like, oh yeah, we're just gonna, do what we can do. And because there aren't like these very established guidelines, but there are definitely groups of lungnoid and some neuroendocrine specialists that actually specialize particularly in lungnoids.
Got it. Thank you very much. Okay, questions are rolling in, so let's get to them. First one comes from Maureen. Maureen says, my husband will be starting FOLFOX soon. Thoughts on this treatment and possible side effects? I'm not super familiar with that, so let's just maybe establish what that is first, and then your thoughts on this treatment and possible side effects.
Okay, yeah. So FOLFOX is chemotherapy.
Okay.
And I think in this disease, we have to kind of separate things that come under the umbrella of chemotherapy because they affect your whole body, but that the injections that we give also affect your whole body, but they're targeted therapies. So sometimes we call those biologics. So chemotherapy is like poisoning the whole organism in order to poison cancer cells more. Chemotherapy in general in this disease is treating higher grade variants. So we have the grading system. And if people are aware of some of the other resources that are online, there are patient advocacy groups and videos on the importance of grade and how that contributes to medical decision making. So FOLFOX is a chemotherapy. It is of established benefit in higher grade tumors, and so we can make that assumption in this case. The key side effect profile of FOLFOX, it tends to give you heat and cold insensitivities, in particular cold insensitivities, so that you get this tingling and it can be very disturbing to some patients. But that if you live in Florida, you're going to have a totally different ability to tolerate. It's the oxaliplatin chemotherapy that causes that side effect, versus if you were trying to get the same drug in Buffalo, New York during the winter. But other than that, it is actually a very well tolerated chemotherapy, and oftentimes people can actually work on chemotherapy if that's important to them.
Got it. Thank you. And thanks so much for your question. Next one from Terry. Hi, Dr. Maluccio. Hope you're doing well. Can liver lesions be nets? Can they be active and grow for 1 year and then be stable for a few?
So the short answer to that is yes. So neuroendocrine tumors most commonly metastasize to the liver. So we really understand liver metastases well. That's why we will tend to focus on control of the disease in the liver. We have a number of treatment options that are particular for that organ site. So the control of neuroendocrine, if I go into my hokey ways that I give analogies, is really if you have a low grade variant that's got a receptor status on it. That's the thing that we're checking for on a PET scan. I call those parking spaces. And then I say that a lot of the drugs that we're trying to do are like sending you a little cars in, and they're trying to find the parking space. And like a police officer putting a boot on the car, it's trying to cripple that cell. It's trying to mess with the mechanisms by which it divides. But unfortunately, the cars are just driving because they're a drug. They're driving, and so you're going to park, and then it's going to go off, and then it's on. So the boot's on the car, off the car, on the car, off the car.
Oh, wow.
And so the cells are going to try to take advantage of when they are less suppressed. And it's not as if that's only, neuroendocrine specific.
Right.
We use hormone receptor blockers in something like breast cancer.
Yep.
So the balance between the treatment that you are using and the ability to suppress it is what gives you that sense that things grow and then stay put and then grow and then stay put. although I put that in, this is the favorable aspect of the disease. The less favorable aspect of that is that there is an expectation that it will slowly grow over time, prompting us to have to make other medical decisions.
Mm-hmm. Thank you for that. And I love your hokey analogies. I don't find them to be hokey at all. I think that for me, visually, like I'm a filmmaker, right? So visuals are always super helpful. So I love the parking spot concept. That really resonated with me. There was a question I saw a little bit further down the list that applies to the receptors. It says Jim says, what research and clinical trials are you aware of currently for patients who do not have somatostatin receptors?
Yeah, so that is an area that is actually being heavily studied.
Mm.
And so because we are so comfortable and fairly confident with our ability to target the somatostatin receptor, there are studies out there trying to use medications that would potentially force a cell or encourage a cell to put those receptors back, on the cell surface. Those are only in clinical trials. And if I were to put, say, oh, hey, look this way, if that is something you're particularly interested in, Iowa, of our neuroendocrine subspecialty programs, they've really been leading the way in some of the studies trying to determine whether or not you can encourage somatostatin receptor expression, whereby we would be able to use some of these somatostatin receptor driven therapies. Now, just because I just know Iowa because we have a really, really great partnership with them. I think there are also probably other centers that are looking at that question as well. It's just I probably start with Iowa because I know that they are.
Got it. Thank you. Next question from Pat. How would you treat a 6.2 centimeter in the liver when there are many smaller ones? And this is the secondary from the pancreas. I've been on cabozantinib the last year. However, I've been stable, but no real shrinkage of the large liver tumor. At this point, would you consider surgery?
Yeah, so that's actually a great question. Is it Carol? That's actually a really great question, because that's when you're going to see some philosophical differences between the neuroendocrine subspecialty centers. I do want to reiterate what Rain said earlier, is that we actually all get along really super well, super collaborative. There aren't enough of us to take care of all the patients with neuroendocrine. So, but when you get into philosophical differences, it doesn't mean that any of us are right or wrong. Mm-hmm. So I can just tell you that our program has tended to be somewhat more aggressive at debulking or trying to decrease the disease burden, whereby you have less parking spaces so that the drug can potentially work better. So when you then say, okay, well, what's on the menu for being able to eliminate or diminish a sizable tumor within the liver? So then you say, well, surgical cytoreduction, that's when we are taking out some component of the disease, but not able to remove the entirety of the disease. That is a proven benefit in neuroendocrine. It's just very individual specific. The data is strongest in metastatic mid-guts, but it doesn't mean that there is no data in metastatic pancreatic neuroendocrine. And we all agree that taking out 10% of a total disease burden is likely unhelpful. But if you can push that up closer to 70%, then it becomes helpful. So no one's going to be like, that's crazy town, if you can meet that 70% goal.
Yeah.
So, but that doesn't mean that surgery is the only option. Liver-directed therapies, we call those embolization techniques, or catheter-based liver-directed therapies, are 80% effective at giving an objective response to treatment. And so I really have a low threshold for at least putting that on the menu and discussing it with someone, because that's very good for an individual tumor that is only 6 centimeters. The analogy that I use, hokey, is that's like going to the state fair with your little air rifle, and you're going to the arcade with all the targets that are coming up, and the interventional radiologist is exploiting the tree-like branching pattern of the liver. And depending on where the 6 centimeter tumor is, they can pretty much go and say, oh my gosh, that's the $10,000 target. I'm just going to shoot it right there. And they're going to put blinders on to the smaller foci, because those aren't the ones that are problematic. Yeah. But in taking out the 6 centimeter tumor, you may very well raise the odds of the additional therapies being able to to keep the smaller disease
Mm-hmm.
in check. So I like to at least have that conversation with patients, but I also would not criticize another doctor's opinion saying, are you really seeing the forest through the trees, or are you just focusing on the one that's kind of slapping you in the face?
Yeah.
And I would say, oh no, as long as the patient understands, we're really focusing on the thing that's slapping us in the face, but we are looking at the long game.
Makes sense. Makes sense. I love it. Thank you. Thanks for your question, Pat. From Susan, is it possible to have one tumor that is both positive CDX2 and negative CDX2 within the same tumor? How common is that?
No, well, the commonality question is going to be very difficult to say, because everything is going to be based on sampling error. The problem, with the way tumors grow is they are a mixture of cells. It's kind of like saying that you have Thanksgiving dinner, and you look around the table and you're like, hey, yeah, we are definitely not all cookie cutters of each other. And were you to pluck one person off the Thanksgiving dinner table, that person may look very different to your Aunt Sally over on the other side. So it is actually not uncommon at all that cell types in a lot of different tumors will have mixtures of different expression of whatever mechanism is going. Now, when you think that is a pathologic mechanism for which there's a targeted agent for it, the degree of cells that are CX2 positive or anything, yes, actually drives our confidence that targeting that would be effective.
Got it. Thanks, Susan. Appreciate that. Next question comes from Shane. Dr. Maluccio, what are your thoughts regarding a second liver debulking surgery? I've heard this question before. 3 years ago, mom had a liver debulking with concurrent distal pancreatectomy, but lots of liver tumors were left behind. They're not visible enough to remove almost all of them. Anything that we should be aware of? Lanreotide and embolizations have kept her stable since then.
Yeah, so I would say that I would agree. Once again, like we said before, there's probably going to be some individual aspects of the disease that drove that decision making. Now, I can say that we would probably have agreed with that decision making, which is that if you're going in to take the primary out, you would try to at least meet the 70% cytoreduction, because that's the thing that's a benefit. I think we are a lot more conservative. When we're talking about going back in, reoperative surgery is always associated with a higher complication rate. The first shot is almost your best shot at doing it. And so I probably would have also, I'm going to say, hey, I think whoever is giving you advice seems like they have a very good head on their shoulders. And I would say that stick with the plan until we have a problem that for whatever reason is not working. And now I will say, I forgot to mention this at the beginning. He was saying, is there anything kind of exciting coming down the pike? I think there are other ablative techniques that are going to be even less invasive than the current thermal ablation techniques that we are using. And so I would just hang tight, because I think we're going to be able to knock off liver tumors with even less invasive techniques in the future that would potentially be able to do individual tumors that are, kind of misbehaving.
Got it. Thank you. And Tammy says, what new drugs are on the market for carcinoid secondary liver other than lutetium 77?
Okay. So there are. So that's one of the things that's probably been the most exciting over the last maybe 18 months. So lutetium-177 or Lutathera is a beta particle. Beta particles they're causing DNA damage. It's radiation therapy causing DNA damage. But the cell, just kind of like the boot on the car, the cell has mechanisms. We call it DNA repair mechanisms, because it's trying to repair itself so that it doesn't, die. Yeah. So the introduction of alpha particles, which are the ones that are in active clinical trials now, and I don't think there's very much doubt that they will likely get through the FDA. Alpha particles are just more effective at doing double DNA damage, and therefore trying to really impair the cell's ability to upregulate the genes that help its repair its DNA. And those are now almost through phase 2. They're going into phase 3, which is the very last stage where the FDA then approves it for this indication. So I think that there's exciting stuff on the horizon for therapy, meaning for trying to get a better response. And that doesn't have to necessarily do with liver. It has to do with anything. It could be multi-organ site involvement, alpha particles, PRRT are now on the horizon. Now, drugs, on the other hand, are also coming down the pike. There are new depot injections where the entire goal is to try to determine whether or not patients would be able to start injecting themselves with a little bit more ease than trying to figure out how to give you that big needle yourself. I think that's huge. That may be a game changer for patients in the South that live far from an infusion center. It's an additional burden, once again, financial burden, transportation burden on it. And then there are oral medications that are coming down the pike. Those are just primarily for those symptom control. And yes, I think that the preliminary data is suggestive that those are also going to be effective and potentially be able to shift people off of injection therapy. But that's not necessarily, that's kind of a trade-off of one. We're just trying to make maybe something a little bit more easily accessible to people, and not necessarily that we're bringing in some major change in chemotherapy. And then we're using a lot more genomic testing, which is when we send the tumor for some additional analysis and determine whether or not there is a drug out there that would actually target some of the mechanisms that are involved. So we call it genetic testing when we test the human being. We call it genomic testing when we test the tumor. And so those types of biotech companies that used to be like two of them, now they're like 15 or 20 of them that will have panels to try to determine. And because neuroendocrine is rare and very heterogeneous, we're actually allowed to take drugs that are potentially lung cancer drugs, melanoma drugs, cholangio drugs, and we're able to actually use them in neuroendocrine patients.
Got it. Thank you. Hey, folks, if you just joined us or joined us a little bit late, this is Luncheon with the experts at Carcinoid Cancer Foundation program. And I just want to say great questions so far. If we don't get to your question, which most often we can't get to them all because there's so many of them, but that's why we continue to have the show. I want to make sure that you reach out to CCF to continue to get answers to your questions in between shows. This is their website right behind me, carcinoid.org, and a special announcement that we're still very excited about our partnership with LACNets to continue to provide that support through a support line for all of those affected by neuroendocrine tumors. And so this support line provides guidance and resources and referrals to net patients and their loved ones, etc. And so this is something that allows us to continue providing that support for patients. So if you need that support or have questions after the show is done, you can reach out to us directly, or you can reach out to lacnets.org/support line, and you can fill out a questionnaire there. Let's continue on with the show. We are about halfway done, so let's continue getting to these questions. Next one comes from Florian, our friend from Germany, who is usually here almost every episode. Good to see you again. Hello, can a biopsy be done in the left upper lobe of the lung with a bronchoscopy?
Well, it all depends on location. So when we do bronchoscopic biopsies, it's because you have to go down through the airway, and then it has to be close enough to the airway in order to be able to access that tumor. So the farther it is away from the bronchoscope, the less likely you're going to be able to do that. I would say the vast majority of bronchopulmonary neuroendocrines that we would do bronchoscopically are going to be the ones that are either in the airway themselves or very close to the airway. Yeah. If it is within the substance of the lung, either as a primary or as a secondary site, that's when we will usually use image guidance. It's usually going to be a CT guided biopsy. And I don't think that necessarily the risks of one or the other is that much different. So it's really the approach is going to be based on the location.
Got it. Thank you. Appreciate your question, Florian. Hope you're doing well. Next question from Sarah. Sarah says, what do you recommend when I have many bone mets in most of my bones, grade 3 Ki67 of 25, small intestine, liver, bone, and skin tumors. So what are your thoughts on bone metastases?
So bone metastases in and of themselves. So how I would have actually described that scenario is we call that multi-organ site involvement. It sounds a lot worse when you say multi-organ site involvement because it's not like we don't have therapies for that. So then depending on the somatostatin receptor inhibitor, the somatostatin receptor expression, We really like being able to use a radioisotope type thing like PRRT. And PRRT is one of those things where it's like an equal service provider, is that it's really looking at the somatostatin receptor avidity. Now, if a lot of the disease is in the liver, we feel like the liver is a little bit of a hungry hippo. So it tends to probably lose a lot of its activity within the liver before it gets to the bone, but it is very good for the bone. Now, if we're just talking about how we manage bone metastases, we will often use therapies that target the bone that are not unique to neuroendocrines, like zoledronic acid, it's also called Zometa, or Xgeva. Those are really trying to either strengthen the bones and making a less favorable environment for cancers to grow, or that's really trying to focus on the bone metastases. And those are the same types of drugs that are used in metastatic prostate cancer or multiple myeloma or things like that. So those are the systemic therapies that we would use, but that's predominantly focusing on the bones. Symptomatic bone mets, we will often use targeted radiation therapy. It is highly effective. And then grade 3 well-differentiated histopathologic variant, which is what you're describing because it's 25%, that's where the chemotherapy is recommended. Then we would say, well, you're more likely than not going to need chemotherapy. And then chemotherapy is also one of those things that is utilized for multi-organ site involvement. If that patient is interested in some of the PRRT protocols that are doing that, I'm almost positive that the COMPOSE trial, COMPOSE, that's using actinium-225, I'm almost positive that was actually targeting the grade 3 well-differentiated, as long as it had some somatostatin receptor avidity, and that she would be able to look that up online under either like clinicaltrials.gov as part of the NIH thing, or she could probably actually honestly find it on a Google search.
Thank you. Hopefully that helps. Appreciate your question. Ralph says, how successful is radiofrequency ablation for nets in the liver and the spine?
It's good. So in cancer, we will use terminology just so that we can understand expectations. And so when we say that we're doing something with curative intent, it means that we are trying to eliminate that as a variable in the person's care long term. And then if we are using something with palliative intent, we are trying to palliate a symptom associated with a tumor growing in that spot. So the bone, we would absolutely use radiofrequency ablation. Is both therapeutic and it is very good palliation. So microwave or radiofrequency ablation for liver tumors has seriously been used for 30 years. I think the techniques have gotten a lot better. It has been studied extensively in both neuroendocrine and non-neuroendocrine cells. And it is done in lesions up to 3 centimeters. It is done with curative intent, meaning we have a lot of confidence that we will eliminate that tumor with radiofrequency ablation. There are some nuances to it, depending on how close it is to a vein, because you get a heat sink or something, but that it is highly effective. A little bit of the disappointing is that you do have to stick a probe through and through the abdominal wall in order to get there. And then the thermal energy is obviously at the tip of the probe. So it can be painful and associated with some complications of that, of which some of the newer ablative techniques that are coming down the pike are trying to kind of address that weakness and do it with something like an ultrasound technology instead. But radiofrequency ablation is an excellent option for single tumors in the liver.
Got it. Hey, thanks, Ralph. Hopefully that helps. Next question from Steven. Does the gallium-68 scan detect functional and non-functional carcinoid tumors equally well?
So the gallium-68, so functional versus non-functional is not directly related to receptor density. So you can have pancreatic neuroendocrine tumors that are non-functional, but they are very highly somatostatin receptor avid and therefore hot or avid on that PET scan. So gallium-68 will be equally as effective at picking up functional versus non-functional tumors. It is less effective as the grade of the tumor goes up. So that if you get into that G3 well-differentiated category that we just discussed, then the somatostatin receptor avidity or density may actually be down, and therefore the gallium-68 scan is going to underrepresent the extent of disease in that case. That's when we have to shift to a different type of PET scan. We call it an FDG PET. But the gallium-68 is excellent functional versus non-functional.
it. Question from Susan. What are the predominant immunohistochemical stains that should be done for suspected pancreatic primary NETs?
So we use the same histochemical stains that we've been using, maybe not for 20 years, but probably for around at least 10 years. So the more differentiated a neuroendocrine tumor is, the more well-preserved the function of those neuroendocrine tumors are, and therefore the IHC staining for synaptophysin, chromogranin are going to be well-preserved. Now, when they are looking at that staining, and if you look on your pathology report, which is another thing we talk about in some of the patient advocacy groups, is that knowing your pathology report and therefore having a very good conversation with your physician on how we use it. So looking on your pathology report, it'll say 3+, 2+, or uniformly positive, meaning that this is a very well differentiated. It looks very much like a normal neuroendocrine cell, though it is a neuroendocrine tumor, but therefore it is more likely to behave like that tumor. So the IHC scans, the stains that we use, are always the same. Now, when we get into higher grade tumors and we're trying to look at other mechanisms, that's where one of the other callers was talking about different types of immunochemistry. And when we are trying to look for specific targets, that's advanced IHC. And that can be a whole gamut of other IHC that are relevant to more higher grade tumors. So I'm not sure whether that's exactly what the person was asking, whether they're asking about the chromogranin and the synaptophysin, because those are ones that are tried and true. Yeah. Those are the ones we will do uniformly. And then the Ki-67 obviously is also done on immunohistochemistry. That's a proliferation index, also very important in neuroendocrine.
Got it. Hey, thanks, Stephen. And do let us know if that wasn't quite what you were after. Everyone, you can always send follow-up questions, and we encourage that. Next question from Perry. And I've heard this before. Perry says, I've had 4th Lutathera treatments. Okay for about a year, but hot spots formed in several bones, and 2 more treatments are recommended. But what is available after that?
Okay, yeah, that's a great question. My first answer would be that you can't say that the additional tumors that formed after PRRT is considered a treatment failure. So as I said before, the beauty of PRRT is that it is infused through the vein. The little cars can drive anywhere they want, but they are going to distribute. We can't say, oh no, I need you to go to the bone. I need you to go to the bone. They are going to distribute how they distribute, likely related to the somatostatin receptor density that you see on the PET scan. So if they don't see it, if it's not hot enough or it's under the level of detection, that treatment is blind to that. And so it may very well have been effective on the disease that it found. And then we have these other things. If they are somatostatin receptor avid, then additional PRRT strategies makes a lot of sense. Now, if it was really short after the PRRT and we think that perhaps there's a different mechanism going on, then we would say, hey, wait a second, PRRT is one option, but chemotherapy is also another option. Oh, maybe we want to get another biopsy. Oh, maybe we want to send it for genomic testing. So that's where it becomes very individualized. What I would tell that patient in particular is that you're allowed to get 2 additional doses of Lutathera based on current medical policy, but you would also be able to consider that alpha particle that I previously mentioned that's currently on trial. There are going to be 2 alpha particles on trial for patients that have been previously treated with a beta particle like lutetium-177. That's the Action 1 trial, which is actinium-225. And it is the AlphaMedix trial that is PB212, also readily available on a lot of neuroendocrine subspecialty sites.
Got it. Thank you. From Tammy says, my husband has been doing lanreotide injection since 2015, now taking Everlimus, 5 milligrams a day. Do you recommend anything other than those, considering he's not a candidate for PRRT?
Okay, so that's going to be one of those times where I would say I'm more than willing to look over the case and be able to give you better advice, because that is going to be very particular to that. there are certain forks in the road that you're going to reach where we go back to the menu, and Everlimus, sunitinib, PRRT, they're all going to be on that menu. And for some reason, your medical provider chose Everlimus. That is a perfectly reasonable option. It has been tested in neuroendocrine tumors, but that they chose that one when there are other options out there. And then I'd have to understand when they say that PRRT was not in there, was that because of location, avidity, things like that? And then it goes back to the other questions that people had, which is that if I had that predominant problem within the liver, I would be using liver-directed therapies alone or in combination with Everlimus, or I would be using other types of chemotherapy. The thing about Afinitor is that it's probably been underwhelming in our ability to actually see a response and see a really significant survival benefit. It's really about trying to delay progression of disease, but that the short answer is that is a very complicated question and likely going to be related to that. And then because we learned from the pandemic that we can give advice across state lines, is that's when I would say, hey, I would have to probably look very closely in that. Mm-hmm. And I'm likely to agree with all the decisions that were made, but could also put a lot of other things in perspective.
Got it. Understood and appreciated. Thanks for your question as well. Next question from Christina. Christina says, hi, I just finished my second TACE procedure, which has been pretty effective for multiple liver tumors. Original cancer originated at the terminal ileum. Doctor wants to continue to treat that with lanreotide. Now, I am concerned that we be more aggressive and look to surgery to get rid of the original tumor. The doctor thinks, though, it's best to just do lanreotide. Given that information, what are your thoughts?
That's so everything that she just described is 100% according to the guidelines that we use. Okay, got it. The decision that was made was to use liver-directed therapies. That has been used for this disease for like 40 years. It is highly effective, 80%. It is very good if people have neuroendocrine syndrome symptoms associated with the disease in the liver. So then you'd say, well, the fork in the road when you decided to do the liver-directed therapies was going to be based on the fact that lanreotide alone, it may not be enough cars blocking enough parking spaces. And so therefore the liver-directed therapies are trying to beat down that in order to let the lanreotide have a lower disease volume burden and therefore be more effective. And I would 100% agree with that. The lanreotide would be considered the standard of care. But I would say that it's not that we are selling you short by not being more aggressive, is that you do have to be very careful about going in Braveheart style on people that are expected to live a long time and burning bridges and or having it be a trade-off of one problem for a different problem or side effect that affects you long term. With respect to surgery, since we have a reputation for being surgically aggressive, I do feel like people should definitely understand the value of surgical cytoreduction. The strongest data is in metastatic midguts, which is exactly what this patient has. But that I would be putting that on the back burner because the decision was already made and it's working. So we don't mess with what's working. And I completely agree that the standard would be to maintain lanreotide and only start thinking about taking a different strategy if for whatever reason that did not meet our expectations.
Got it. Thank you very much. To a few of you out there with those questions about, I saw Nancy was asking about programs for financial assistance and things like that. We've been responding with links to help people that are asking for trials, et cetera, et cetera. So let me know if those links are helpful or if you have follow-up questions, but just do recognize that within the comments, we've been responding and adding some links to try to get you the answers to those questions. Sean says, does it make sense that samvastatin really helps with carcinoid syndrome, but receptors do not show on the dotatate or Octria scans?
Oh, so that's kind of an interesting phenomena, to be honest with you. Either it's really low volume disease, and so part of the syndrome is being driven by things that are small and under recognized by the scans that the patient has, or the drug is just working, better than expected, and suppressing
Mm.
the tumors to the point where you aren't seeing the receptors, that probably would also be something unique to that thing. It doesn't, I wouldn't say that it happens that commonly that things that are not receptor avid are also contributing to significant carcinoid syndrome, for which then samvastatin would have an effect. It's almost like it's almost multifactorial, but that clearly it's working. And I would say that would be, I think, indirect evidence that it's actually doing what it's supposed to do. And maybe there's just subclinical. We call it subclinical when we don't think that we're picking it all up on the scan. I think there's probably subclinical disease there.
Got it. Thank you. Tammy says, my husband has Y90 on or in 2015 and now doesn't have any elasticity left in his liver. What treatment or treatments would you recommend at this point?
Yeah, that's actually problematic. And so I don't fault someone for using Y90 in 2015. We didn't have a lot of the other platforms other than TACE, and PRRT wasn't yet on the horizon.
Yeah.
So a lot of the neuroendocrine specific. So when I say a neuroendocrine subspecialty center, those are the people that where we do 100% neuroendocrine. And so therefore we're all kind of playing by the same rule book, even though I don't want to, there are many people that treat neuroendocrine patients very well that are not a component of a neuroendocrine subspecialty center. But one of the things that I think we decided as a group is that I don't think we really like Y90 because we worry that perhaps it is going to stiffen the liver and then make you less tolerant of additional therapy that might be needed over a long life. But then again, Y90, if it works, you're like, bonus. So now you would say you would go back to the same menu. It's not that liver-directed therapies wouldn't be available just because of the stiffness of the liver. We just look at the risk benefit a little bit differently. It wouldn't be. There are papers out there that have had PRRT after yttrium 90, and it has been given safely and not associated with significant side effects. So I don't want to necessarily say that that's not down the pike. When you start to get into chemotherapy, which is all metabolized and broken down by the liver, you don't want that to be a trade-off of one problem for a worse problem or worse toxicity associated with that chemotherapy. So I feel like I'm answering a lot of these questions the same way, which is that is actually a very patient specific. More than happy to take a look at the case and say it, because I lived my pre-neuroendocrine life. I lived it in primary and metastatic tumors of the liver, and we delivered a lot of yttrium 90 to other types of cancer. Yeah. So I'm familiar with it in both neuroendocrine and primaries, but that it makes medical decision making a little bit more complicated.
Noted. Thank you for that. I think this is a good question. Laurie says, does having PRRT now preclude having alpha therapy later?
No. So if you've had, it's all about the timing. Now, obviously, clinical trials are not a guarantee that therapy will get through the FDA. But the reality is, I think we've seen a lot of progress, a lot of evolution. More has happened in neuroendocrine in the last probably 5 to 8 years than probably happened in the previous 20. So we know a lot about alpha particles from Europe. I think we are now very comfortable with alpha particles in the US. We just have to go through the appropriate channels in order to get it approved so that then we can take it off the shelf and offer it to people like anything else that we have available. So the clinical trials that are currently on, so if you've had previous beta therapy with Lutathera, you can get 2 additional cycles of beta. But if you get the 2 additional cycles of beta, you will not be eligible for the clinical trials that are available because you would have reached the threshold of exposure to make you eligible for the trial, because you have to have less than 880 millicuries over the course of your entire lifetime. So you would then have to wait. But I usually tell people that have slow growing tumors, we aren't going to cry any tears over having to wait, because if it becomes commercially available, we will be able to utilize it as an FDA approved medication for you. But if that's the advice that someone's giving you right now for treatment, and you are looking at additional beta, which is a very reasonable option, versus alpha, which is a very promising new therapy coming down the pike, I'd probably at least look at whether or not you would be able to take advantage of the alpha particle on trial, because in our world of neuroendocrine, it was that patient population, or this patient population that we're discussing, that was actually kind of a little bit more interest to us than just using alpha versus beta at the original decision to use PRRT. So we're finally getting that answer, and that answer is being tested in 2 different types of alpha particles, actinium-225 and Pb-212.
Got it. Thank you. We're going to keep plugging along because we've got 8 minutes left and lots of questions. We're going to try to get as many as possible. This is coming in from YouTube, since we are now simulcasting there as well. Tina says, is a net diagnosis possible without a biopsy confirmation?
Oh, well, that's a tough question. I think my short answer would be no, unless it is so obvious on a somatostatin receptor PET that someone would say there's no way that you can have something with that level of avidity, we call that hotness, that level of hotness, that would not be a neuroendocrine tumor.
Yeah.
So my short answer would likely is that we are reluctant to say that someone has neuroendocrine without it being biopsy, proven somewhere.
Understood. Thank you. And thanks, Tina. Thanks for joining us. Melinda says, does the gallium copper scan light up neuroendocrine only?
So the gallium and the copper, 2 different agents, but similar. It's a somatostatin receptor PET. And the short answer to that is yes. You can have non-neuroendocrine things that will take up that. And we have to understand, is that something that's associated with degenerative joint disease of the bones? Is it associated with ovarian type issues because the ovary has somatostatin receptors? Is it related to a multinodular goiter because the thyroid has somatostatin receptors? But that now that we are super duper comfortable with the contemporary gallium-68 and copper-64 somatostatin receptor PETs, I think that the PET imagers are pretty comfortable calling something, suggestive of versus physiologic. Physiologic means that we think it's associated with just either normal or non-net abnormal, like a goiter.
Got it. From Lydiana, is there any scan without radiation?
Well, an MRI. So it all depends on what you're looking for.
Yep.
So the radiation dose of a PET is actually less toxic than some of the radiation that we use with a much longer CT scan. I will usually tell people that that even though when you're following someone over a long period of time, that seems like a lot of imaging with radiation, unlike other cancers where, like in kids and things like that, where there may be some consequences to it, we don't see it as much in neuroendocrine, where we say, I believe that is a complication of being surveyed for years with these techniques. I think the techniques have gotten pretty good with reasonable radiation doses.
Got it. And the last of a little bundle here of kind of rapid fire questions. I just had it from Skip. Does lanreotide have a statistically known shelf life?
Oh, I'm sure like any drug, it does. If you were to look on the box, I want to say that it's 90 days. So, but like any drug that you would have, it's not that it goes from being effective to 0, but that the calculated dose will slowly weaken over time, just like any drug.
Got it. From Christine, I had 12 rounds of PRRT and have recently been diagnosed with severe MDS. How common is this, and shouldn't oncologists be more aware of this? Yeah.
So what I don't understand about that question is we don't give 12 rounds of PRRT. MDS, which for the rest of the audience is myelodysplastic syndrome. That is when the radiation dose or the treatment, whatever it is, whether or not it be chemo or in this case radiation, ablates the marrow, whereby you are unable to actually rejuvenate your cells and keep your counts up. So the short answer to that is yes, MDS is a known complication of PRRT type treatment. It is extraordinarily rare. I think it is probably maybe 1 upward towards around 2%, depending on the patient population that you're looking at.
Yeah.
We worry a lot more about it in people that are heavily treated, like have been treated with chemotherapy and PRRT, so kind of a double hit to the marrow. And if that person did not mention MDS as they were heavily treating with PRRT, that was probably an oversight or something where it just wasn't highlighted to the extent that it is. Now, we don't necessarily highlight it. We highlight a little bit of myelosuppression and some kidney changes. So we don't highlight something that happens unusual, but I'm sorry that happened to you, because MDS is a very challenging thing to treat.
Yeah. Don't some countries do more rounds PRT than we do in the US?
Yeah, they do. They do it at a lower dose, though. So if you're talking about just cars, so the cars with the little radiation particle on them, they're going to bind, but your body is a machine. So it's going to circulate. And then as each circulation goes, you're going to lose some in your kidneys. There's nothing you can do about it. You can't like plug up the kidney for a while so that you get a little bit more rounds. So the strategies, which seem like they would logically make sense, but I don't quite know quite enough about radiation to understand it. Okay. It does seem reasonable that you would give lower doses and you would just give it more frequently over a much longer period of time. Yeah. And get the same, once again, short game, long game. And it just seems like it's very reasonable. So that would explain the 12 rounds. Okay. But my prediction is that it was a lower, and by doing a lower dose and more rounds, you're more likely to be able to sense when someone is going to start having irreversible marrow-related problems like MDS.
Got it. Thanks for clarifying that. Probably last question, but we'll see. AG says 2 questions about your practice and facility, please. Is it correct that your physicians are still able to provide telehealth appointments with patients outside of the state of Louisiana? That's the first one. Let's take that. Is that
okay? So that's actually pretty easy. So what the pandemic taught us is that if you have a rare tumor, it is very hard to find someone that really feels like they see enough of that tumor to give you advice on what should happen and some of the treatment options. Yeah. So our program, because we are the subspecialty program for the whole South, we are licensed in the whole South, and the pandemic allows physicians to do that now through something called the compact agreement. So the short answer is yes, we can give advice to anybody, anywhere. But that if we are not licensed in that state, you can understand. I mean, we don't want like quacky, like going across state lines. So we just have to give you advice, but it has to go through a person. So say, for example, Florida. Florida is not part of the compact agreement, but we have many medical oncology partners in Florida that help manage our patients in Florida. And yes, I see them over the virtual platform and I give them advice. It is just a service that we have. And I am blessed. I hope that maybe, LSU isn't like watching this, is that I'm blessed that no one tells me I can't do that. Mm-hmm. But that I will tell you that there are other health systems that don't want to take that. But it has to be, if I'm not licensed in that state, it is really that I'm giving the advice to your doctor. Yeah. And the doctor is ultimately the one that is treating you. But that's what these patient advocacy groups are so good about, is just kind of getting you the advice that you need, and then relaying that advice to people that are licensed in the state and ultimately primarily responsible for you. And I think that's the system working.
Got it. And the second part of that question, which I do want to get across because I think this is important, is there a physician in your practice who will treat a child diagnosed with NET cancer? If not, what other facilities are you aware of that could provide this care?
Yeah, so we do. We just do it through our children's hospital. So I don't know whether or not there are practices. Maybe Iowa, because
you took the words out of my mouth. Yeah,
exactly. She is a pediatric person. Yeah. So definitely Iowa. Even though Sue Odorizio did, I think, retire from clinical practice, she still probably lives large in their world.
I don't doubt it.
But that is one where under the same umbrella, they were likely treating kids. Yeah. The rest of us that are really live in the adult world would likely be doing that with partners that are within our same, organization, but it would be at the children's hospital.
Got it. And thanks, AG, for that question. I think that was important to highlight because there's this misconception that this doesn't happen to younger people, and it does all the time. And in fact, we did a video with Dr. Sue Odorizio about NETs in children, and we've done several of our documentary series with either adults now who were diagnosed as children or some children So you can view some of those. By the way, we have 2 more of those patient documentaries coming out soon. And one more final announcement before we go. In 2 weeks, and I will announce this on the Facebook page and other places so you'll see it, but just as a pre-announcement, in 2 weeks, we are having another program that is a non-Luncheon with the Experts program, but still very informational that you all will be interested in. Dr. Maluccio, thank you so much again. I want to read one comment from Laurie that says, Dr. Maluccio, you are so relatable, practical, knowledgeable, and informative. Thank you so much. I agree with all of those points, and I always appreciate having you on the show.
No worries at all. And I'm also very verbose, but but for those of you
the analogies.
Exactly. She's like, can she ever just answer a question
No,
and like
I
move
love
on?
No, what we call that here, Dr. Maluccio, is being thorough. That's all that is. That's being thorough. And we appreciate your thoroughness. And we appreciate you all in attendance as well. As always, we hope this program helped answer some of your questions. I'll reiterate again, if you have follow-up questions or we didn't get to your question, you can reach us at carcinoid.org. That's our site, or at lacnets.org/support line. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals, because we couldn't do the show without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye now.
Bye.